All right, everyone. Well, welcome to the Hemophilia Council of California and our first policy and advocacy webinar of 2021. This is the state of healthcare in California, what you need to know. My name is Lynn Kinst. I'm the Executive Director of the Hemophilia Council of California, and I want to welcome you today to our webinar. We also have with us Terry Cowger-Hill, who I'll be introducing in just a moment. Who will also be helping provide an update on what is happening in our state capital.
So the governor is setting aside money for the new CalAIM proposal. Those of you who followed our budget memos in the last year know that CalAIM was a proposal that was actually put forth last year, but because of the pandemic was put on hold. We see 1.1 billion put into the budget. That's a large number, and that's because the governor and his team feel very strongly that it makes sense to provide whole person care for those that are in the Medi-Cal Managed Care program in California. And most adults are in Medi-Cal Managed Care if they're part of the Medi-Cal program. We have protected a lot of the CCS eligible children, and so many of them are carved out of Medi-Cal Managed Care, but most adults and some of the CCS kids are in Medi-Cal Managed Care plans. So this is primarily a proposal to better coordinate physical health, behavioral health, and oral health care services under the Medi-Cal Managed Care program for the adults. It does require a federal approval, but again, the discussions have been ongoing and most believe that it will have a good chance of getting approved. Next slide. So another large proposal that's in the budget for this year as proposed is CalRX. We talked a lot about CalRX last year, but just to refresh your memory, it was in discussion last year, but not fully approved. And it is a proposal to save $621 million in the state of California by moving most of the prescription purchasing from Medi-Cal Managed Care to a fee-for-service system. So there are 5 components of CalRX. The first 4 I'll cover quickly. Number 5 is the one that's most impactful for those in the hemophilia and bleeding disorders community. So it would create a Medi-Cal best price proposal for drugs, additional rebates for non-Medi-Cal drugs that goes into the state budget to help fund CCS and GHPP. So I guess technically number 2 is also important for our community. Number 3, it would increase the state's purchasing power. Number 4, it creates a new generic drug contracting program. And number 5, the Magellan contractor with the state of California would be processing all claims for outpatient drugs and for drugs in the home setting starting April 1st, 2021. Now, originally, CalRX was supposed to begin January 1st, 2021, but they really want to get it right. And they know that with COVID, there are a lot of problems with getting everybody trained. And so if you are a pharmacy that is part of the Medi-Cal or that serves Medi-Cal patients in California, we would recommend that you contact the state of California if you have not already done so. Go on the CalRX webpage and make sure that your pharmacists are properly trained so that when the April 1st date comes up this year, which is only a few months away, you'll be poised and ready to go to be able to process claims that are for factor and other drugs that are delivered to our consumers in the home setting. Next slide. So the governor is keeping his eyes on the California pocketbook, as is the legislature. As I mentioned, we have a huge budget surplus for this year, but it's really perceived by the Nonpartisan Legislative Analyst Office as a one-time surplus. And so we can't just spend all of the money or we won't have enough to go around for next year. So a couple of the spending or savings proposals, I should say, include the CalX proposal that I just discussed, but also the new reimbursement rates for factor that were set in place July 1st, 2020.
So This is Lynn again. We wanted to just mention and talk about how have these new rates impacted patients with bleeding disorders. We've already sort of talked about the new rates and the fact that it went into effect on July 1st. We've been monitoring to see if there's been any access issues that impact the bleeding disorders community. At this point, we don't have reason to believe that this has been a huge stumbling block for access, but we recognize that some of the effects may take time before they start impacting patients directly. So we just want to continue to remind everyone who is watching that we need your assistance to identify access issues that arise. So if you or a patient that you're working with experiences an access issue related to their treatment or their medication, we would ask you to reach out and let us know what is happening with that, so that we can we can see what advocacy may need to take place in order to remove those barriers to access. Similarly, there's the question of whether or not Medi-Cal RX may impact patients with bleeding disorders. In the state of California, our factor replacement products have been treated differently than most other drugs as something that's been carved out of Medi-Cal Managed Care and reimbursed separately by the state previously. So under Medi-Cal RX, this will continue, but all pharmacy benefits will now be carved out, as Terry was just describing. We began a dialogue earlier this year with the Department of Healthcare Services to ensure that patients will continue to receive their factor and other medications in a timely fashion when CalRx goes live on April 1st. And we have been assured that Magellan will be following the department's policy for factor and other medication, but we will continue to watch it closely. And while we don't expect patients to see any difference after April 1st, anyone who experiences a delay or a denial should reach out if they need assistance, just like with what we were describing with the change in rates. We would ask you to help be our eyes and ears and let us know if you see that problems that are occurring. I know there was a question in the chat. Do we think that the deadline for Magellan is going to be extended? And Terry responded and said, it could be further delayed, but as of now, the state has announced April 1st. And if that changes, we will certainly let everyone know.
Yes, and we will also do our best to answer questions in the chat room at the end, since it's hard for us to see while we're presenting. So the fee-for-service and Medi-Cal Managed Care, the best way to describe this is many of you that have private health plans, fee-for-service is sort of similar to a PPO plan. And managed care is similar to an HMO plan like Kaiser or Health Net. But with Medi-Cal Managed Care, it's a little bit different. So this slide is going to try to describe a little bit of that for you so you understand it better. So Medi-Cal fee-for-service is where doctors and other healthcare providers are paid for each service performed. The consumer usually has a broad choice of providers. The states create their payment methodologies, and the fee-for-service has historically, for Medi-Cal, typically been used to address high-need populations with severe chronic illnesses or individuals in remote areas. So for example, the CCS program, which is the California Children's Services Program for infants and children all the way up to age 21 who have hemophilia or other related bleeding disorders, they are primarily in a fee-for-service system if they also have Medi-Cal eligibility, except for the CCS whole child pilot, which we'll discuss a little bit later. Everyone else in Medi-Cal in California is pretty much in Medi-Cal Managed Care. So most adults, most GHPP patients also have Medi-Cal will be in Medi-Cal Managed Care unless they have a special exemption. And so Medi-Cal Managed Care pretty much organizes the care services with the goals of being more efficient and to lower costs. It does have more restrictive networks and prior authorization is often required. there are a variety of systems in California under Medi-Cal Managed Care. One that you hear a lot about is the county organized health systems, and that's the one that's part of the CCS Whole Child Model Pilot. But there's also the two-plan model where, say, if you live in Alameda County, you have a choice between the county-run plan or the private plan that contracts with the state. So you have two choices. And then if you live in LA and you're under Medi-Cal Managed Care as an adult, you pretty much have LA Care, which used to be a smaller network, but because LA is so large, they now contract with a variety of plans to provide services there. Core features of managed care are integration of financing, insurance delivery and payment, and formal control over utilization. Factor has been carved out of Medi-Cal Managed Care since 2014, and that was done by the advocacy work at the Hemophilia Council. We had advocated for many years that managed care didn't necessarily fit our community, and in particular our Factor. And so the state decided back in 2014 administratively to carve Factor out, and now the other drugs, the subcutaneous shots that patients and consumers get, is also carved out as well. Next slide. So how does managed care affect patients with bleeding disorders? So the Hemophilia Council of California has been monitoring the CCS Whole Child Model Managed Care Pilot that I mentioned. Historically, with other rare disease colleagues, we have kept the CCS and GHPP patients out of managed care. We also lobbied, as I mentioned, for Factor to be carved out. But during the past 3 years, a small subset of CCS eligible children and young adults have been rolled into this CCS Whole Child pilot. The largest county that's part of that is Orange County with the Cal Optima plan. And then there are a lot of Bay Area and smaller rural counties that are included in the Whole Child Model pilot. Managed care can be successful for our community, but we must remain vigilant to ensure that managed care does not erect barriers to appropriate treatment. You can all help us by reporting any issues that your community members or consumers experience. So other proposals that the Hemophilia Council of California will be watching or actively working on this session. We will be introducing a resolution declaring March as Bleeding Disorders Awareness Month in California. This has been a longstanding agenda with our partners at NHF, and we have been successful in introducing that each year. It's a wonderful tool because a resolution does not have to be signed into law by the governor. It's simply put into place after being heard on the Senate and the Assembly floors in Sacramento, and is chaptered by the Secretary of State. But it's a wonderful advocacy tool that we use on our advocacy days in April and May. And this year will be virtual again. And so that will be a great tool to educate new members of the legislature or members that we meet with on that day. We also anticipate that step therapy measures will be reintroduced from last year to help the community. We will be following all of those. Copay accumular adjuster bans and copay caps will likely be addressed as well, and we'll partner with our friends at the California Chronic Care Coalition, Arthritis Foundation, and others on those proposals. And then if the budget doesn't address the telemedicine proposals, there may be legislation to address that as well.
So we just want to remind everyone that some of this is simply proposed. Most of it actually is simply proposed at this point and is not yet final or complete. So please continue to stay engaged with the Hemophilia Council because your voices are critical to help shape these proposals into policies that benefit and do not harm our community. Thank you so much for joining us today. Again, the slides and the resources page will be up on the website later this afternoon, and we will get the video edited and up in the next couple of weeks. And we really appreciate you joining us today. Hope that you found this helpful, and just say thank you again to our sponsors, to BioMarin and HF Healthcare for helping to make today's webinar possible.